Well, good evening, everybody, and thank you very much for joining us tonight. We have a fantastic session tonight on chronic pain, where we're going to be focusing on the paradigm shift in opioid prescribing and where that currently sits. I'm Sandy Vincent from the PHN Education team, and I'm joined tonight by our presenters. Dr. Vidya Shirumwala is a pain specialist working in the Central Coast Integrated Pain Service at Gosford Hospital, and Lorenda Cook is a physiotherapist working with the Central Coast Integrated Pain Service. We're very grateful to have you both with us. Before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on. For me, that is Darkinjung land, and pay my respect to elders past, present, and emerging. A few things to let you know about tonight's session. We are recording this session. The recording will be available in our PHN Education Library in a couple of days' time. As attendees, your cameras and microphones are currently disabled. If you do have questions during presentation, please pop those into the question box. You'll find that located in your control panel. We'll definitely make time for questions at the end of the presentation, or we'll make time for you to unmute your microphones and ask your questions directly. An evaluation will come to you at the end of the session. Please do complete that. Your feedback is important. And this activity has been accredited for 1.5 educational activity CPD hours. Also a reminder that this webinar is part of a series. There is an Echo Hub session which is happening on Tuesday the 30th of May, in which we'll have a live interactive case-based discussion on chronic pain. I'll be sending you an invitation to that at the end of the session, and we really hope that you can join us then. Right, so it's now my great pleasure to hand over to Vidya, who's going to start the session for us. Okay. That looks perfect. Thank you.
Fantastic. Thanks, Sandy, and thanks to everybody for joining us tonight. I'm Vidya, Dr. Vidya Shirumwala, the pain specialist in Central Coast Integrated Pain Service, and I've probably met or dealt with most of you at some point or the other. Today, so I'm going to get started without any further ado. My patient wants opioids. What do I do? So I know Sandy has already acknowledged the country, but I would like to briefly acknowledge the country again before I go any further. I'd like to acknowledge the Aboriginal people, the traditional custodians of this land, and pay respect to our Aboriginal elders, both past and present. CCLHD is committed to closing the gap in health deficiencies in Aboriginal health. So today we're going to talk about the paradigm shifts in opioid prescribing and where the pendulum sits currently, and what are the latest developments in opioid prescribing approvals process, the real-time prescription monitoring, which all of you are familiar with in the form of SafeScript, the interface of chronic pain management with opioid replacement therapy, and ways to manage pain flare with minimum reliance on opioids. That'll be the point of discussion. That'll be what Lorenda is going to talk to you about. So how did it all start? How did we end up here with this opioid epidemic? So there is this article from 1986 with 38 cases by Portnoy, where they trialed different doses of opioids for different periods of time, and they noted few substantial gains in employment or social function attributed to institution of opioid therapy. This was the beginning. Regardless, this was taken up as an acceptable clinical practice based on this article. Based on this case report, rather. And now, Dr. Portnoy, doctor who was paid by Purdue to push opioids to testify, has agreed to cooperate with lawyers in return for dropping legal actions against him. So that's where it's ended up. A pain drug champion has second thoughts. So he's basically backtracked from his own work. So how and why? Where did corporate greed and where and how did corporate greed fit into all of this? The promotion and marketing of OxyContin, commercial triumph, public health tragedy. One of the big major cornerstones of Purdue's marketing plan was the use of sophisticated marketing data to influence physicians' prescribing. They used a very lucrative bonus system, encourage sales representatives to increase the sales of OxyContin in their territories resulting in a large number of visits to physicians with high rates of opioid prescriptions, as well as multifaceted information campaign aimed at them. What did this really involve? And I'll get to that in a minute. If you want to know it in more detail, there is a TV series, Dope Sick, which exposed the greed and shame of the US Big Pharma, and it reveals the shocking truth behind America's opioid epidemic crisis. And they employed the largest sales force in pharmaceutical history, and one of the major talking points for this sales force was that there is less than 1% risk of people getting addicted to to OxyContin. How can you get that number? And we'll get into that in a minute. If you don't have access to Dopesick, there's another cheaper version. There's this $12 book on Amazon, Dreamland, written by Sam Quinones, and he chronicles the rise of, amongst other things, opioids or OxyContin addiction in US, and this is an award-winning book. So I'm going back to that key question. How did Purdue Pharma come up with that 1% risk of addiction? Back in 1980, in NEJM, which is obviously a very highly reputed journal, there was a small 4-sentence letter written by Jane Porter and Herschel Dick, describing addiction-related outcomes for the Boston University Medical Center's patients who had been prescribed opioids. Boston, as you know, is a very high-profile center, and the patients that are, as you'll realize later, were inpatients. So the letter states that out of 11,000 plus patients who received opioid medications, only 2 of them ever developed a dependence on the drug, and only one of these was a major dependence. Although it was published in what many would consider to be the world's most prestigious journal, NEJM, the authors didn't think much of it at the time. It was at the bottom of a long list of studies performed by these authors, and and the letter itself didn't attract much attention for the rest of 1980s. Everyone had pretty much forgotten about it, including the authors. But that was until Purdue Pharma, the manufacturer of OxyContin, picked it up, and they quoted this letter as evidence or the basis for their claim that the rate of addiction for patients who are treated by doctors is much less than 1%. And in their commercial, they want people in pain to become prescription OxyContin users. However, the scientific study from which the commercial's 1% addiction rate statistic is pulled does not apply to prescription OxyContin users. It applies only to patients undergoing hospitalized, regimented care, a very different environment to self-administration. So what is the risk of getting addicted to OxyContin? The lifetime prevalence of addictive disorders has been estimated at 3 to 6% as per this article published in 1984. However, we lack any large methodically rigorous prospective studies addressing this issue. And there were a whole heap of studies looking at it. And a recent literature quoted the incidence from 0 to 15% based on the criteria used. So that's a far cry from the 1% that Purdue was proposing. So did Purdue get away with it? Misrepresenting the risk of addiction proved very expensive for Purdue, and they had to pay $634 million in fines. So that happened. That was back in 2007. But what happened to the opioid prescribing in US? In US, opioid prescribing increased fourfold during 1999 to 2010. Opioids were increasingly prescribed in higher doses and for longer durations, and those prescribing behaviors were attributed to or associated with opioid use disorder and overdose. And what was the consequence of this sort of opioid prescribing practice for patients in pain? There was a fourfold increase in overdose deaths, and there was a significant increase in prescription opioid use disorder. In 2015, 12.5 million people aged over 12 reported misuse of prescription opioids in the past 12 months in US, and 2 million people met the criteria for opioid use disorder in the last 12 months. Then came the 2016 CDC opioid prescribing guidelines in US with the aim of do the right thing. Let's fix this problem. Let's fix the problem created by corporate greed. We want to make sure that clinicians and patients get safe and more effective pain treatments. They want to improve the outcomes of patients, and we want to reduce opioid use disorder. We want to reduce overdose. We want to reduce prescription-related opioid adverse effects. Prescription opioid related adverse effects. So that they wanted to do the right things, and that's why they came up with these guidelines. But what actually happened? There were problems. Oops, something went wrong. And what was it? Inconsistent with the central tenet of the guideline that the recommendations are to be voluntary and intended to be flexible and support, but not supplant individualized patient-centered care, they were extended to patient populations not covered in the guidelines, such as cancer care and palliative care. Along with that, there was rapid opioid taper, there was abrupt discontinuation without collaboration with patients. There was a rigid application of opioid dosage thresholds. So what was the consequence of all this for the patients? You can imagine it can't be good. It was untreated and undertreated pain. They had serious withdrawal symptoms. They had worsening of their pain outcomes. They had psychological distress. They had overdose and suicidal ideation and behavior, and patient dismissal and patient abandonment. So how does the 2022 CDC opioid guidelines address these shortcomings? They're now trying to fix the problem. This guideline provides recommendations, but does not replace clinical judgment and individualized patient-centered decision-making. And this guideline also states that recommendations should not be used as inflexible standards of care. Neither should they be used as absolute limits for policy or practice. So some of the key points of CDC 2022 guidelines include determining whether or not to initiate opioids for pain. So it's good they've made a guideline on this. I think that's a great decision. So in acute pain, non-opioid therapies are at least as effective as opioids for some of the common types, and clinicians should try and maximize use of non-pharmacologic and non-opioid pharmacologic therapies, which is non-steroidals, heat pack, cold pack, TENS machines, stretches, so on and so forth. And they should discuss these therapies with the patient, not impose it on them. They shouldn't just be saying, oh, you've got pain, I'm never going to give you endone. Let's sit down and discuss what are the other things we can do for you. That would be a good way to start. And for subacute and chronic pain, it's fairly similar. Non-opioid therapies are preferred. Clinicians should maximize use of non-pharmacological and non-opioid pharmacological therapies. Before starting opioid therapy for chronic pain, again, the clinicians should discuss all the various options and everything that's involved. And they have talked more about holistic measures. So one of the big things that you will notice if you actually decide to sit and read the 100-page CDC 2022 document is, of course, they've said no to opioids. But one of the important things is when they bring up their model of other holistic measures, they rely too heavily on passive treatments. The issue with passive treatments is if the provider of the passive treatment, say, for example, the chiropractor saying, come to me every single time you have pain, and I'm going to do some manipulation and fix you, we have a problem with that approach. We would like it more if they go to some provider like a physiotherapist or whatever it is, who says, here are some exercises that you can do now, and here are some posture and ergonomic corrections that you can do, or this is something you can do for your balance, or so and so, so you don't get into this situation. And if you get into this situation, here are some of the exercises that you can do to make yourself better. So somebody who empowers them. So we support more of those holistic measures where there is some sort of active measure provided to patients. And I'm sure Lorinda is going to talk more about this after me. And the next important component of CDC 2022 guidelines is selecting opioids and determining opioid dosages. So here in the guideline, it says when you're prescribing opioids for acute, subacute pain, consider immediate relief, which is fine. Immediate release opioids. In Australian clinical and regulatory framework, in chronic pain, we commence patients on long-acting agents only, as we are addressing the background pain, and pain flares need to be prevented or managed holistically. So one of the big background points for this selection is that, or this choice in the CDC guidelines, is that when OxyContin came through Purdue Pharma, they were trying to say that it is better than having back-to-back doses, like 4 doses of endone at regular intervals. OxyContin's heaps better. So there were good quality studies done head-to-head to compare 4 doses of 4 doses of regularly taken endone to OxyContin, and they found that there was actually no difference. So because of that, the CDC guideline says it's actually okay to give that immediate release for chronic pain as well. But here we don't. In Australia, we don't. So let's agree to disagree. We do disagree with them on some points. If you are to commence opioids on a chronic pain patient after having trialed everything that you could have possibly trialed, we would rather you put them on long-acting. So when opioids are initiated for opioid-naive patients with acute, subacute, or chronic pain patients, clinicians should prescribe the lowest effective dose and should avoid increasing dosages above levels likely to yield diminishing returns in benefit relative to risks to patients. That's quite well agreed upon, and most clinicians are aware of this. For patients already receiving opioid therapy, clinicians should carefully weigh the benefits and risks and exercise care when changing opioid dosage. If benefits outweigh risks of continued opioid therapy, clinicians should work closely with patients to optimize non-opioid therapies while continuing opioid therapy. If benefits do not outweigh risks of continued opioid therapy, clinicians should optimize other therapies and work closely with patients to gradually taper to lower dosages, or, if warranted, based on the individual circumstances, appropriately taper and discontinue opioids. So basically, regardless of whichever pathway the patient is, they want the clinician to work closely with the patient and try to use all non-opioid based, non-pharmacological strategies and try to taper them down while working collaboratively with the patient. Unless there are indications of a life-threatening issue, such as impending overdose, opioids should not be discontinued abruptly, and clinicians should not rapidly reduce opioid dosages from higher dosages. And the duration of follow-up, when they're no longer needed, you should obviously wean and stop in chronic or stop in acute. And this lines up with Australian practice of limiting opioid pack sizes upon discharge. And clinicians should evaluate the benefits and risks of after commencing opioids in a patient within about 1 to 4 weeks of starting the treatment. So I would totally agree with that. That's in the CDC guidelines, and that's similar to what we practice here. So some of the key takeaways from CDC guidelines is that it's underpinned by a whole person biopsychosocial or socio-psychobiomedical approach. It acknowledges that flexibility for clinicians and patients is paramount when making patient-centered clinical treatment decisions. And the other important thing that it acknowledges, and which I haven't mentioned so far, is that there is no way to predict who will experience opioid-related adverse effects and who will experience the benefit. So we need to be cautious with everyone. So with that background, we need to now think about what's actually happening in Australia. We're going to look at the ground reality, which is a sobering statistic from Pennington Group. We're going to look at what health initiatives are currently working, and we're going to look at some real cases. So we're going to look at the opioid stewardship program, the real-time prescription monitoring through SafeScript, and what are the changes that have been proposed. So Pennington Institute, I've looked at their website, and for those who are not familiar with Pennington Institute, they're champions. They describe themselves as champions for open, rational, and compassionate approach to building and sharing knowledge to reduce drug-related harm. And they believe in approaching drug use in a safe, considerate, and practical way, and they're seeking solutions, not scapegoats. So their report is actually a sobering statistic. So what they're saying is America's opioid epidemic is Australia's future if we don't act now. So if you look at the number of unintentional drug-induced deaths by drug type in 2020, it goes all the way, it starts all the way from opioids and goes all the way to cocaine, but the highest number is still with opioids. And there's a whole heap of other statistical information available on their website, which you can go through in your own time. But of course, I do notice, and I'm quite concerned, that opioids are on top. And if you look at more information or more graphs on the website, it shows that most of it is prescription opioid. Clearly, illicit drug use is not okay. There's no two ways around it. Now, prescription medications other than opioids featuring in this overdose report include benzodiazepines, antidepressants, anticonvulsants, antipsychotics, cannabinoids, the synthetic ones mainly. So are we taking our patients off all antidepressants and antipsychotics indiscriminately? Oh, I know antidepressants can cause overdose. It comes up on the Pennington report. So you can't be on antidepressants, you can't be on anticonvulsants. So we're not doing that, are we? So in fact, antidepressant and antipsychotic overdoses have much higher lethality. They're much more difficult to treat. So what I'm trying to say is we need to focus on rationalizing opioids and not penalizing and abandoning patients in pain. I'm not by any means saying, yeah, go ahead, put all your patients on opioids. Not at all. All the guidelines, the CDC guidelines that I painstakingly went through, and everything that I've been saying so far, it just still says that you need to rationalize and minimize opioids and work with your patient to develop other holistic ways of managing pain instead of penalizing and abandoning them. Some of the other information that I got from the Pennington Institute website is that there are no stereotypical drug users. It just doesn't exist anymore. People come from all walks of life. They could be from the lowest echelons of society to people right at the top. And the reasons could be any number of things that have derailed their life. So after road traffic accidents and suicide, overdose is the next most common cause of death for Australians in their 20s, 30s, and 40s. It's a no-brainer that these patients need more support, not abandonment. According to the Pennington Institute, 35,000 Australians have died from overdose in the last 20 years. So basically one family losing a loved one to overdose every 4 hours. And people from Aboriginal or Torres Strait Islander origin are 3 times more likely to die from overdose. Death rates are also higher in rural and regional areas. The problem, what they feel, is that the shame, stigma, and embarrassment associated with overdose-related deaths keeps people from discussing those issues. They would rather say that my loved one died from an accident rather than from an overdose. The cost of overdose to community is estimated at $16 billion a year, and it can't be ignored any longer. It's only going to get worse unless we address it. Pennington Institute is pushing for a national overdose prevention strategy that brings together government, police, health professionals, researchers, and importantly, people with lived experience to deal with the overdose problem in a realistic way. This again suggests that people whose life is derailed and are using any of these drugs, especially opioids, they should be supported, not abandoned. Now, the other thing that I wanted to highlight was the second drug in the Pennington report was benzodiazepine, and that combination of opioid and benzodiazepine that we see so very often. That is not good. A US FDA review found that the growing combined use of opioids with benzos or other drugs that depress CNS has resulted in serious side effects, including slowed or difficult breathing, and deaths. So they've actually issued this drug safety warning. And there's a whole heap of references, and depending on which paper you look, the increased incidence of adverse effects, the incidence seems to vary based on the paper you look. So it comes down to, what should I do? Don't you worry, we've got you covered. Here are some health initiatives and some strategies that might help. So this is the all too familiar opioid risk tool. This tool should be administered to patients upon an initial visit prior to beginning or continuing opioid therapy for pain management. A score of 2 or lower indicates low risk for future opioid use disorder, and a score of more than or equal to 3 indicates high risk. So that's a fairly simple tool, and you can just Google and have it saved there on your desktop so you can use it anytime. That's the reference. The 6 A's. Now we've all been taught 5 A's, and that is used to monitor opioid use in your patients. The 6th A is accurate records, which is obviously not just your record keeping, but also checking real-time prescription monitoring, such as SafeScript. I'm sure everyone in the audience will be familiar with the 5 A's: the activity, analgesia, adverse effects, aberrant behaviors, and affect. Now, opioid contract. Most of us have heard about it. There are many variations available. Pick one that you're happy with, and I've given you a sample of one that looks pretty good. The main advantage is that this makes patient accountable and makes it easier for you to retract from opioid prescribing if they breach the terms of the contract. But it is time consuming, as you need to spend enough time to build a therapeutic relationship and explain everything. You can't just drop an opioid contract if you're seeing the patient for the very first time. You need to really know the patient well and develop that therapeutic relationship before you go into this. Now, opioid analgesic stewardship. This is one of the health initiatives that's currently in place. It does have a definition. It's coordinated interventions designed to improve, monitor, and evaluate the use of opioids in order to support and protect human health. And what exactly does it include? It includes consideration of opioids, as well as other analgesic and adjuvant medications, and strives for a balance between analgesia that is sufficient to facilitate patient recovery and restoration of function, and minimization of analgesia-related harms to the patient and others. So that's what the guideline looks like. It's available if you look it up on Google. It's freely available. One of the key takeaway messages from this really lengthy document is that 1 in 4 who undergo surgery are at risk of becoming persistent users of opioids. And that 1 in 4, if you actually put into perspective that 2.5 million Australians undergo surgery annually, based on that incidence of 4%, about 100,000 people are at risk. And that's why it's quite important to de-escalate the opioids in the post-operative period. That's where your role as the community GPs becomes quite important. So predictors of poor post-op pain control. Pain, as we all know, is a very individual experience and quite subjective at times, and it can be affected by psychological, cultural, social, and environmental factors. And the predictors of poor postoperative pain control include younger age, female sex, smoking, preoperative anxiety and depression, pain catastrophizing, preoperative pain, and preoperative opioid use. And this is, again, the reason why I put all this up is it's not because you're sitting an exam where you need to, rattle out the reasons for poor postoperative rattle out the reasons for poor postoperative control. But basically, one of the things that's become quite topical now is the patients often complaining that I can't see my GP for X amount of time. And I realize your service is valuable, but if you could kindly see the patients soon or promptly after their discharge, post-surgery, or after admission for an acute event, that'll be very helpful. Other key takeaways from these documents: instead of chasing unidimensional pain scores with opioids and raising expectations while managing acute pain, it's better to focus on functional endpoints. So the functional activity scale that we commonly use in hospitals is this one. It has A, B, C, 3 levels. No limitation is when the patient is able to undertake the activity without limitation due to pain, and mild is when they're able to undertake the activity but experiences mild to severe pain, and the severe is when they're completely unable to get out of unable to complete the activity due to pain. So an example of no limitation in the hospital setup would be when the patient's getting up and walking around, going for a cigarette every few hours. And mild limitation is when they can just take themselves to the toilet and back. And severe limitation is when they're in right in bed and they can't even take deep breaths. The other key takeaways from these documents is that we don't really want to completely abandon the pain scores while managing acute pain, but it's the pain score trajectory that matters. Trajectories that do not decrease over the first few days after surgery have been shown to be a predictor of chronic post-surgical pain. And opioid dose trajectories are also a good indicator of patient progress. The risk of persistent opioid use is higher in those whose opioid dose trajectories in the immediate postoperative period are not decreasing. Hence, again, soon after discharge, it would be nice if they could see their GP and start working towards opioid wean. Now, I'm going to go through some of the real cases that I've seen in my role here as staff specialist in the pain clinic. Mrs. PT, a 59-year-old female with chronic back pain as well as pain in other sides. She had quite complex mental health problems and quite profound psychosocial stressors. And I thought when I was talking to her and doing my review, I wondered how she's going to go, but I was very surprised when I asked what her medications were, and she said, I'm only on this, this, and this. But when the GP had made the referral, she was on a whole heap of other things. So I asked, how did that transition come around? She said, when she first went to see her GP, and the GP started telling her to start weaning from all these medications, she thought, what would my doctor know about my pain? She just wants me to get off medications. But then she decided to start looking up the side effects of these medications. And when she saw she didn't like what she saw, and she didn't want to be on these medications, so she basically self-initiated her wean, despite quite profound mental health problems and quite complex psychosocial stresses. So after having seen that, I realized it's very important for the patients to know where to look for the side effects. So I tell my patients when I see them face to face is that you should, if you really want to know what's wrong with these medications, you go to a reliable source. You look up TGA, or you look up NPS, or if you want, you can even look up FDA. Don't go to Dr. Google or one of those chat forums. And some of those really motivated patients who really want to look after themselves might, that's all they need. Another real case. Mrs. LP, a 76-year-old female with chronic lower back pain, previous L2-S1 fusion, and severe degenerative changes in the unfused spine about it. She's got multiple complex comorbidities. She's had ischemic heart disease for she's had CABG for her ischemic heart disease, apologies. She's had previous DVTs and PEs. She's got hypertension, type 2 diabetes, heart failure with preserved ejection fraction, AF, cardiorenal syndrome with deranged renal and liver function, and recurrent infections after her right total knee replacement. And currently, she's managing a deep-seated right buttock open wound. According to her, wound dressings per se were not a pain source at all. So she was on Norspan 30. Remember, she's a 76-year-old with multiple comorbidities. She's on Norspan 30, pregabalin 75 BD, and Panadol Osteo 6 to 8 a day. So the altered biomechanics from the L2 to S1 fusion and the ensuing severe degeneration in the adjacent spine, as well as recurrent infections post-TKR and the ongoing buttock infection, would all add to her pain experience and functional attrition. She was able to engage in a meaningful discussion and coherently presented her side of the story. She's been through multiple pain-related interventions, pain programs, and rehab in the past, and she's over it. She has multiple medical comorbidities, and she just merely wishes to be comfortable, have some good quality of life. She acknowledged the risks of high-dose opioids, including but not limited to respiratory depression and death, and was also made aware of the harms associated with supratherapeutic doses of Panadol Osteo. She was taking 8 instead of 6 a day with the cardiorenal syndrome. Together, we decided to change the treatment of goals to comfort care to maintain her quality of care, her quality of life. However, as she keeps representing to the hospital with reversible acute illness, such as infections that are amenable to antibiotics, wound care, etc., we left a proviso that all acute presentations should still be managed, and discussion about resuscitation needs to occur if and when she presents acutely unwell. I'd CC'd the pharmaceutical services to the GP letter to cover myself. Another real case. Now, we don't have to go and agree with opioids for everyone. In the last case, it seemed like the most reasonable thing to do. But this is a different situation. Mrs. B.H., 73-year-old female, chronic multifocal pain on a background of depression, anxiety, panic attacks, and adverse developmental history. She's on a number of pain medications: Targin 15 by 7.5, Ordine syrup 5 milligrams per mil, half a mil, 4 hourly, PRN every day, maximum dose 15 milligrams a day, Endep 50 milligrams, Nocte, Tuloxetine 60 milligrams, extended release Mane, and pregabalin 150 milligrams BD. And she's a 73-year-old who lives by herself. And she's got severe COPD with FEV1 of 2.6, which is 26% for her, with nocturnal hypoxemia. And she's been recently commenced on nocturnal home oxygen by respiratory department and by her respiratory specialist. She lives by herself, and she admitted to having really poor compliance with her home O2. I turn the oxygen concentrator off at night as it's too noisy. That's the time when she desaturates. When challenged about ongoing use of all her pain meds, she replied, "I don't like using oxygen very much. I leave it off often. So I couldn't see how strong opioids could be continued for chronic non-cancer pain in a frail elderly female with nocturnal hypoxia. She was unable to hold meaningful conversation, unlike the previous patient. I've suggested that her goals of treatment be changed to comfort care and the GP to refer her to palliative care. And palliative care could see her as a stable phase patient. Not every palliative care has to be, in the last days of life. Again, I've CC'd the letter to pharmaceutical services to cover myself. So that is another way of dealing with things. Sometimes you need to be patient. Some things take time. Not all cases have a good outcome straight away. Some could take years to get there. This is another real case. Mr. JG, a 64-year-old male with chronic multifocal pain from osteoarthritis, managed long-term on opioids. His past medical history includes drug dependence with past illicit drug use. He has used intravenous heroin, THC, alcohol, cocaine, benzodiazepines, and opioids. He's got bipolar affective disorder with drug-induced mania, and his history of presenting illness includes a trial of THC CBD, which was prohibited by cost. It wasn't effective enough, although he gets better sleep and still drinks alcohol. The GP referred him for opioid authority and also holistic programs in the past. He declined holistic programs in the past, which were offered by the previous pain specialist who had seen him. And then back in 2016, he was jointly seen by the then pain specialist and addiction medicine specialist who offered him opioid replacement therapy, which he declined. He didn't engage with the mental health team in 2018 and self-seized the medications initiated by his psychiatrist, namely paliperidone, for that, the drug-induced mania, bipolar, and so on and so forth. He was on Capanol 20 in the morning and 30 at night. He's on diazepam, 5 milligrams BD, and some irbesartan. When I reviewed him last time in 2022, I went through SafeScript and noticed that he was getting some early scripts. Instead of coming every 4 weeks, he was coming at 2 or 3 week mark. So in my letter, I highlighted that to the GP and suggested that they stick to 28-day repeats only. And the GP did her job really, really well and reinforced the same with the patient. For fear of losing Capanol authority, he decided to be fully compliant with the same. In addition, he even stopped drinking, and he noticed that the first time in forever he was in the best headspace. He was financially heaps better off without drugs and alcohol. And he eventually got there, even though it took forever. It took a long time. Agree, not every case has a good ending like this one. There's lots of people who never get to this level, but it's a good case. Another real case. This is really interesting. We had this young 31-year-old with Crohn's who'd lived with Crohn's from the age of 12, who had been diagnosed at that age, and he used to get 2 monthly anal debridements. He's well known to a whole heap of private specialists, and some in public and some in private. He was referred to us in 2021 by his private gastroenterologist, saying that once he attends our pain clinic, they will not be prescribing him any further pain relief. And I took that seriously because that was actually what was written in the referral letter. So I saw him first in December 2022, and he was taking 8 to 10, according to his history, he was taking 8 to 10 OxyContin, 30 milligrams, 2 at a time. Outside of the peri-procedural pain flare, now this peri-procedure is the 2 monthly anal debridement for his Crohn's, his background perianal pain is generally manageable. But his OxyContin requirement has escalated over the years. He's now taking 8 to 10 tablets of 30 milligram OxyContin to manage essentially what appears to be his withdrawal symptoms. That was his history. That's exactly what he told me. And he described them quite clearly, that he gets sweatiness, restlessness, a feeling of bad hangover, with some perianal pain should he not get his next OxyContin dose. He had good insight. He knew that this is withdrawal and not pain. Besides, 30 milligram OxyContin doesn't do anything for me. I've gone cold turkey before without any problem, and I'm interested in holistic measures and coming off opioids. I thought, wow, that's fantastic. We're going to make lots of progress here. I was getting really excited. And I said, okay, come off the OxyContin, go onto some Norspan patch, and we'll link you up with our psychologist. But as you would expect, he didn't turn up for the psychology appointment. He deferred using Norspan patch on the grounds that he does not have a GP. For someone who's been diagnosed Crohn's at the age of 12, requiring 2 monthly anal debridements and known to a whole heap of specialists, he does not have a GP. And that was where the red flags were going on. And he expected us, as the pain team, to either act as his GP or help him find one. We gave him some suggestions on how to find a GP and set some boundaries around our role. He eventually went and found a GP who then trialed him on Norspan. Around this time, after this initial interaction with this patient, when I didn't have access to SafeScript, SafeScript then became available to me. And when I looked up his entries on SafeScript, I was shocked. This long-term private gastroenterologist had been prescribing 28 tablets of OxyContin, 30 milligrams, every 2 days consistently since April 2021. And based on this, his OMED was 630. Then we scheduled a joint appointment with addiction medicine specialist, Dr. Shorzewicz, who's no longer working with us, which is a shame. There is a difference. During this joint appointment, I pointed out to him that there is a difference between requiring opioids for managing postoperative pain after his 2-monthly anal surgeries versus low-dose opioid substitution to manage withdrawal. He's not to blur the lines as both conditions are different. The 10 microgram Norspan patch was never going to work if he wished to manage his acute nociceptive pain after recurrent perianal surgery. He again clearly tried to identified himself as opioid tolerant, and also that he might even be developing opioid-induced hyperalgesia. So he had really good insight, which used to confuse us all the time. But thanks to SafeScript, we knew things better now. Given that he had an OMED of 630, he needed to go on to ORT, which is opioid replacement therapy. A letter was sent to all his healthcare providers, and he was commenced on ORT through drug and alcohol. He is now on a stable dose of 32 milligrams Suboxone with 28-day pickup and 1 observed dose, urine drug screen, and 3 monthly reviews through drug and alcohol. At this stage, if there is anyone in the audience without SafeScript, please register for it now. It only takes 5 minutes, and that's all you need. Now, SafeScript is real-time prescription monitoring. It's a computer software that provides prescribers and pharmacists with real-time information about a patient's prescription history for certain high-risk medications so that they can make safer clinical decisions at the point of care. It collects prescribing and dispensing information about monitored medications via the electronic prescription exchange services that are already connected to most prescribing and dispensing systems. However, it does not collect any information about whatever we prescribe in the hospital or upon discharge, unfortunately. However, the main strength of SafeScript is that it can capture information through other community dispensing, even if the patient has opted out of My Health record. And it raises alarm if the OMED is more than 90, but leaves the clinical decision making to the clinician. The monitored medications include opioids, benzos, some of the sleeping pills, and some of the psychostimulants, and some other specific Schedule A drugs such as ketamine, pregabalin, quetiapine, cannabis, etc. And the beauty of this is that you don't require any software. You can use it's a web-based platform, and you can just use it on any device. Once you're registered, you just log in and then access the information. So, what is the current opioid prescribing regulatory framework? Some of you might be thinking that I know all about it, probably more than me, because I don't actually do the prescribing. Why is there a slide on this? I've actually had a few GPs who refuse to prescribe opioids to their patients, and basically they said they do not know how to prescribe, so which was a surprise. And this happened a few months ago, so that's why I've included a few slides on that. So if you want to prescribe a Schedule A drug for pain management, you need to go to New South Wales Health, and this is what you just put up. You just put New South Wales Health in your Google search. This isn't intranet, this is not hospital intranet, it's not part of anything, it's just Google search, and then this page comes up. Home pharmaceutical services, medical practitioners, and go to prescribing a Schedule A drug. That's the link for the page. According to New South Wales Ministry of Health, you need authority to prescribe drugs of addiction, which include the opioids, as I mentioned before, and an authority is required to prescribe or supply a drug of addiction for a drug-dependent person, a non-dependent person who is prescribed or supplied the following for more than 2 months: any injectable form of any drug of addiction, any drug of addiction for intranasal use or spray, alprazolam, buprenorphine, except Norspan. But even if it's Norspan more than 2 months, you require an authority in this day and age. Flunitrazepam, hydromorphone, methadone. The other component of prescribing, apart from getting that authority, the second one is you need to get the authority from Medicare Australia, which is for the purposes of subsidy under the Pharmaceutical Benefits Scheme. Authority is not required to prescribe a drug of addiction to a person who is admitted to a hospital or is an inpatient unless the inpatient stay exceeds 14 consecutive days. To apply for this, you can use a PDF form and send it. And there is talk of making this process automatic on a purpose-built web portal, so watch this space. So some of the authorities on the PBS are streamlined, and some of them you need to call and get the authority. So if there is a streamlined code, you can use that, or if it isn't, you actually need to ring. Or if you don't want to ring, there's another way of doing it, but ringing is obviously better because it actually works 24/7 and you get your authority number pretty much straight away. That's the PBS one that I'm talking about. And when you do ring them, you need to have all the information about the patient and all the other details about yourself and about the drug. Have it handy before you ring them. And so again, if anyone wants to look up more under this, that's the same website. You Google New South Wales Health and that comes up. Go to Home Pharmaceutical Services Medical Practitioners, and that's where you get all your information. If you are to prescribe ORT, that's the other drug. Those are the other forms to use. So coming to the ORT section of the talk, or opioid replacement therapy, I wanted to go through the science behind it. So in our brain, we have the ventral tegmental area, which produces dopamine, which is released here into the nucleus accumbens that gives a sense of pleasure. But for a normal person, the prefrontal cortex would tell the ventral tegmental area if this pleasure is being obtained by an unsafe and unwise mode, such as by using drugs. And locus coeruleus, as I'll explain later, also plays a very important role. But some of these set points are changed in addiction. So these are set to release dopamine in the nucleus accumbens to produce pleasure. But opioids cause addiction by initiating a very vicious cycle of changing the set point, such that the release of dopamine from here to here is reduced when normal pleasurable activities occur, but opioids are not present. So the release then is coupled with opioid alone. So the pleasure is only with opioid. In addition, what happens in locus coeruleus, like I said, it has an important role, is that every time new opioid receptor binds to the neuronal cell wall, there is conversion of ATP and cAMP is formed, and through this converting enzyme. But over a period of time, as tolerance develops, this is reduced. Instead of 3, you're only making 1 molecule. So as the tolerance develops over a period of time, inside the neuron there are some changes, and it compensates and picks up the CAMP production. And disconnected from this, it's not related to opioid. It's not related to opioid occupying the mu receptor. And it does this because you eventually need to produce some noradrenaline, which is the main chemical produced through locus coeruleus. And that noradrenaline is required for maintaining a normal level of wakefulness, muscle tone, respiration, and so on and so forth. So there's again a change in the set point in locus coeruleus such that noradrenaline release is increased during withdrawal. So what it is that over a period of time, as you develop tolerance, the neuronal cell continues to make the CAMP and release noradrenaline. So when they suddenly withdraw, so before withdrawal, if there's opioids here and there's increased noradrenaline, the two are offsetting each other. When the opioids are suddenly withdrawn, there is nothing to inhibit, and plus that there is this unopposed action of noradrenaline, and that's why patients get those symptoms of withdrawal. So this set point theory gives both the positive and negative aspects of drug addiction. And that's the reference for that. So the abuse potential of opioids can be predicted by three sets of characteristics. Drugs with a shorter half-life have a greater abuse potential, heroin more than methadone. Drugs with higher lipophilicity cross the blood-brain barrier more rapidly and are more likely to be abused, heroin more than morphine, and that more than methadone. Finally, those drugs with a faster route of administration have a higher abuse potential, such as injectable intravenous drugs obviously have a higher risk of addiction than subcutaneous injections or oral. Heroin, which has diacetyl morphine, which means the two acetyl groups, that makes it much more lipophilic, enabling it to cross the blood-brain barrier more rapidly than morphine, thereby making it a preferred drug for injecting opioid abusers. So this is the natural history of opioid dependence. With the same dose of opioid, initially they go from normal to euphoria, and they quite quickly drop back to the normal. They take the drug again, and they're going into the euphoria and quite quickly drop back to normal. It's only during these periods that they feel good and quite quickly drop back to normal. But once they keep using it for a certain amount of time and they develop tolerance, the administration of this drug only leads to normal. It doesn't actually lead to euphoria zone at all. And just to even feel normal, they need to take something. Or else they go drop into the withdrawal zone. So that's when they've got tolerance and physical dependence. How does ORT work? For buprenorphine-based preparations, which is often prescribed through our very helpful drug and alcohol team, which I'm very grateful to for them for this, as a partial opioid agonist, it binds tightly to opioid receptors but does not fully activate the receptor. Because of this sealing effect, there is no significant respiratory depression regardless of the dose ingested. This, coupled with slow onset of action and the combined formulation with naloxone to reduce the illicit intravenous use of the medication, was thought to limit the abuse potential of this medication. And how does methadone work? It's highly lipophilic, long-acting, and orally effective medication that controls craving and opioid withdrawal after a single daily dose. In company with counseling and other supportive services through our kind drug and alcohol department, up to 70% of addicts are able to eliminate their opioid use. In conclusion, individualize your patient's treatment. Please don't abandon patients on opioids, even though they're hard work. Use non-pharmacological and non-opioid steps at every possible state. While using opioids, start low and go slow. Immediate release opioids for acute and subacute pain, and sustained release opioids are for chronic pain if you have to use them. There is no way to predict who will experience opioid-related adverse effects and who will experience the benefit. And always CC the letter to pharmaceutical services to cover yourself. Only doctors and pharmacists are under their jurisdiction, not the patient, so there's no concerns about patient confidentiality. But you can always let your patient know if you think the patient's going to take that against you. Last but not the least, you can't make everyone better, so don't beat yourself up for it. Like I said, sometimes it takes ages for the patient to get there. Sometimes they never get there. Okay, so now I'm going to hand over to Lorinda, who's going to talk about ways to manage pain flares without opioids. And if in case there are any questions, I'm happy to take them as well.
Thank you so much, Vidya. That was amazing. There aren't actually any questions at the moment, so I think we will get Lorinda to start her presentation. So if you would mind, stop sharing your screen and then I can change that over.
Mm-hmm.
Wonderful. Thank you so much. And we'll come back to questions at the end. So everybody, please do use your questions box if you're thinking of any questions in the meantime to pop those in, and then we'll make sure to share those with the presenters. Otherwise, I can ask you to unmute yourselves after Lorinda's presentation. Thank you.
Thank you. So I am a physiotherapist and I'm with the Central Coast Integrated Pain Service. And I'm part of the allied health team that helps to run programs designed to assist people who have been living with pain, a pain experience for more than 6 months, to try and change the way they live with their pain, so that it becomes a fulfilling life despite their pain. Often our participants will say to us that they've had enough of the medications, they've had enough of the side effects, they're over it and they want off, but they can't imagine what they're going to possibly do without medication when they have a pain flare. So this whole idea of no meds, but what about the real pain? What about the pain? And so we need to try and help develop, and we do try and develop some other strategies to help the pain. But we also need to recognise that these strategies need to be developed before the medication's removed. A lot of the skills need to be there, and it needs to be, I heard a lovely analogy, it's like a patient or somebody clinging to a log in a river. If you take away the log before learning to swim, it can be a catastrophic result. So we need to try and help them develop some of these strategies before we start to remove all of the medication. For this to be successful, though, the person needs to understand and believe that there is a neuroplastic component to their pain. They need to acknowledge that there are other perceived threats, other things that are going to wind up their pain experience, that it's not just tissue damage, it's not a diagnosis, it's something else that might be creating that feeling of the senses of danger and not being safe. And that effect of catastrophizing and low self-efficacy can actually affect self-management and a successful outcome. New skills and strategies need to be taught, they need to be developed, and we as clinicians need to be there to help and to give them that support and encouragement. And I think we all need to remember that people don't always know that there are other options. People don't always know that there are other ways to do things besides medication. They've been taught from very early on that if you need something, you go to the doctor and he can give you a pill to help that. So we need to actually take that step back and realise that you don't know what you don't know until you realise that you don't know it, and that we need to be the ones that can actually present those options for them. It's also really important to remember that even with the greatest skills and the greatest amount of knowledge and confidence and belief, that sometimes in emergencies, sometimes when things start to go completely wrong, and in a pickle, things don't go smoothly. That the mind can blank out, we can forget what we know, we can forget our plans. And so I think it's really important for us to remember and to help, and we certainly spend some time in our programs for people to start developing a flare-up management plan. So the next few slides are some of the information that I share with our clients when we're doing a program to help them build up a flare-up management plan, to give them the reason why they need to have a flare-up management plan, and just how they might go about actually having that at home. What to do when it feels like it's back. Because while everything's going nicely, everything's on a high, I can manage without my medication. But when that pain comes back, what am I going to do? It would be lovely, and we would love all our clients after our programs to have smooth sailing from here on in, and that their pain is under absolute control and their life is under control and everything's going smoothly. But we all know that that's not the case. We all know that the reality is that there are going to be barriers, there's going to be ups, there's going to be downs, there's going to be setbacks, there's going to be things that happen around them that suddenly sensitize their whole system. There's dangers everywhere that we look, and the road is not smooth. We talk about active self-management strategies, and I thought I might just give a little list of some of those strategies that people can use to be an active participant in their own pain management, rather than the passive strategies that video alluded to in terms of having the chiropractor do their treatment, having the physiotherapist do their mobilizations, taking their medications, sitting back and letting the doctor do the surgery or the procedure. We try and encourage people to become an active self-manager. They're in control and they're doing things. And so some of those self-management strategies are graded progressive activity or exercise, starting small and building up rather than jumping straight in and doing a boom or bust, completely do everything and then have to rest for days, and then try and do everything and then have to rest for days. Chunking and chore management. So chunking activities and chunking chores into manageable sections so that they can then rest when they need to and continue when they can. Breathing techniques and self-soothing techniques are very important. Thought and internal dialogue awareness. Thought control is not a thing, but thought management can be. And just being aware that the little voice inside your head might be telling you some unhelpful things, as well as potentially some helpful things if you start to be aware of it. Sleep hygiene is very important. Communication skills is an active self-management strategy. Being able to express your needs to people around you without winding yourself up and without winding other people up can then calm the farm, calm the nervous system down so that it's not as on alert as it was previously. Acceptance and self-compassion is another active strategy. Being able to recognize capacity and the difference between capacity and capability can give people a sense of ownership and strength to keep going and work through their pain flare or through their pain. And really importantly, being able to reconnect with people, place, purpose, and passion becomes an active self-management strategy for living with ongoing pain syndromes. So flare-ups need a plan, a thump. Everybody needs a good thump every now and again. And we encourage people to be prepared. We need to try and help people work out what they would like to use in their flare-up management plan when things are in a calm state rather than in a crisis or in a chaos. And it's a good idea to actually experiment things when everything's under control, trying different strategies, deciding which skills feel comfortable, deciding which ones work for the individual, and then starting to explore how they go when things are not quite as under control. We encourage people to write down their plan. Putting things on paper, and write is a term that doesn't necessarily mean using words. I'll show you soon, but it can be any kind of visualization, but actually putting pen to paper helps to reinforce the importance of the plan, but also reinforces that content, so that's reprocessing and it's really sinking in. If you've got it written down, it's there for times when stress levels are high and blocking thinking and undermining confidence. And it also makes it significant because it is an entity, it is a thing. It's got its own life now, and it can be easy to access in that times of high need. The other thing that we really encourage everybody to do is to tell someone where it is. Having a significant other, having somebody that you can call upon in those times of higher need definitely gives support. They can help to remind you of the strategies and what to try. But it also helps significant others to not feel helpless in the face of watching somebody that they care for going through a flare. Some of the things that we like to help people think about including on their thump is to start with the active strategies, and then as they trial these, or as they are still requiring more to get through their flare-up, maybe they might need to add some more of the passives down the trail. But it's about, let's start with active first and then work our way through to the passives, with the knowledge that this is for a flare-up. This is not forever. This is to get you through this episode, and we go back to doing all our active strategies later down as things settle down. So some of the things we can include are breathing exercises, and we generally encourage everybody to start with a breathing exercise. 3 deep breaths on your thumb. First thing you're going to do is 3 deep breaths. Give yourself some space, give yourself some awareness. We're going to address this. We're going to tackle this flare up. Trying some movement or positioning, might be stretching, might be a favorite exercise. It might be something in the pool where you're moving a little bit with some support. Distraction techniques, identifying your favorite activities, the people that will be supportive, the places that you have connection to, or a purpose. Distracting yourself with the things that you love and that drive you and fill your cup. Watching your thoughts, making sure that you give yourself space to identify some of the unhelpful thoughts and the internal dialogue that might be driving the catastrophizing. It's very confronting when it's back, when that pain comes back and you thought you had everything under control and you thought that life was moving ahead, and suddenly you're confronted with that same old. So trying to watch those thoughts and keeping them in check is an important part to put down on that plan. I do help people understand that people say to me sometimes, but what if it's something going wrong? And so we talk about red flags and we talk about being a detective and thinking through the symptom check and thinking if it's something new or is it the same old? Are there signs of something else that I might need to go and talk to somebody about? Is there something that needs investigating? Encouraging that same old, that I've been here before, I recognize these symptoms, these are nothing that is new. Those red flags are not red flags because they've been investigated and I know what they are, is another way of bringing the sensitization, bringing that wire up, down. Then we go on to some of the more passive types of techniques, using ice, using some heat, using some strapping or some bracing or some support, thinking about having some therapy, maybe some physio or some acupuncture, going to have a massage or a chiropractic treatment, knowing that it's short term, having a goal-directed treatment session, communicating with your practitioner that I'm needing some help just to get through this flare-up, and then I'm back on my track, I've got a plan. It might include medication, it might be seeking further advice and looking for more in investigations. And we encourage people to recognise that they do have a place when the flare-up is much harder to manage, but to try all those active strategies first, give themselves some control back, and then move on to where they need to actively seek information and advice in a relationship where they are not waiting for somebody to do something for them. Plans can look like anything, and some people would like to use pictures more so and colour more so than words, and that's fine, we encourage that. It can be a pictorial map, it can be a flow chart of things that they want to do to try and guide themselves through that flare up. As I said, putting this down and putting the effort into creating this plan is part of the thing that helps process the information so that they can then really absorb it and know and have confidence that they've got a management plan that they like. It can look like a recipe card, and this is the one that we work with in our groups. We use a brightly coloured piece of paper, and the reason that brightly coloured piece of paper will start to become the trigger for I know what's on that piece of paper, and the more that they look at it and the more that they use it and the more that they have success with managing their flare-up plan, the more likely it is that they won't need to actually open it up and read it. They'll see their little bright purple piece of paper or their bright yellow piece of paper sitting in their wallet, on their notebook, on their fridge, and they go, I know what step 1 is. I just have to not panic and take 3 deep breaths. And so they start to learn what to do. And I always encourage them to write a little phrase that means something to themselves, something about the fact that they know that they're going to get through this, they've been there before, that the flare-up is just a short-term setback, or it's an opportunity for them to practice some of their skills. A little positive affirmation that they can use. There are worksheets that we provide that the ACI have on their website so that they can work through these ideas of what am I going to do if I've got a flare-up. So the Pain Management Network has this Avoid a Flare-Up, Manage a Flare-Up worksheet that can be the plan. It can be the document that they keep ready. The Be Smart, the Be Pain Smart, the brain injury section of the Pain Network has another worksheet which uses the red flag, green flags, so that it marries up, okay, if this is happening, this is what I'm going to do. If this happens, this is what I'm going to do. And so they've got just another pictorial form with words that they can then use to communicate and remind themselves what it is they need to do. And sometimes all that's needed is just a reminder that they have actually been here before, they have had a flare-up before, they have got through that flare-up before, and now they have a whole heap more skills to actually help them create a better path for themselves. Short and sweet, bumps.
Wonderful. Thank you so much, Lorinda. That was excellent. All right. We do actually have some questions. Thank you very much for sending those through. Lydia, would you mind putting your camera back on? There you are. Wonderful. Yes. Okay. Thank you, Samantha. I'll read your questions. Thank you for sending both of those questions through. Samantha is saying, I don't understand when to fill out the New South Wales Authority application.
Oh, okay. So it is like you need to go to the website and it gives you all the conditions when you have to fill it on. But if you want a rule of thumb, it's basically 2 months after commencing the drug of addiction, the drug with which a person can get addicted to, or to which a person can get addicted to. So technically, for the first 2 months, you can start the opioid or benzo or whatever it is, and get away with it by prescribing. And within the 2 months, you need to put the application through for that. Yes.
Thank you. And then the second question from Samantha. I'm finding patients being discharged post-op, ortho and gen surge from JAH on Temgesic, one on a Sunday night with no supply. They then present to the GP asking for a script. It's my understanding that GP should not prescribe this ongoing. What do I do?
Oh, they've just been discharged after an acute event. The expectation is that they then see the GP who works with them towards de-escalation in a controlled way. So really the expectation is that you would still prescribe in lower doses, whatever it is that they were on. We're going to work towards a weaning plan. It's hard to say how many. So if they're on, say for example, they're on 4 of Temgesics a day, and they're like 2 weeks after their surgery, and you can now talk to them about you're 2 weeks after surgery, you really need to be cutting down to perhaps 3 a day and then 2 a day and then, 1 a day and then wean off. So you would still need to prescribe, but in a weaning fashion with a view to wean.
Okay, because I guess that was that the patient did not have a supply.
Yes, so this is another thing that I've actually raised with clinical governance a few times. Our understanding is some of the common established procedures, like say someone coming in with for elective, say hysterectomy or elective knee replacement or elective hip replacement, for which we have data. So all hospitals have certain categories for which the data is collated, and our hospital isn't doing too badly for them. So for them, they have whatever 2 or 3 days in the hospital for their initial stage when the pain's really, really bad, and they get their opioids in the hospital, and then they go home with 2 or 3 days of supply. So their initial 5 to 6 days are covered. So it's after this we expect the GP to review them and do whatever's needed. So it's really hard to specifically answer exactly what happened, why the patient was discharged with no supply. Patients are told that you're going to go home on such and such date. It's not you're going to go home. It's not like they walk in and say, you're going home now. They are given some degree of notice. There is some discharge planning that happens. And for elective surgery, that often starts in pre-op. When they see them in pre-op, there is some plan put in place then. So the idea is that if the patient has had some surgery, they would have had 5 to 6 days worth of opioids through the hospital. 2 to 3 days as inpatient, 2 to 3 days as upon discharge, and they have enough time to contact their GP and say, so and so has happened, help me. But that would be an aberration. That one patient that they saw on a weekend with no medication, that would be an aberration. Something unusual has happened for why they're left with no script and no supply.
Thank you for that. David is asking, what is the current wait time to see a pain specialist at CCIPS? Thanks.
It seems to fluctuate between 6 to 9 months. So for some of those extreme high acuity patients with really dangerous levels of opioids, sometimes, and especially some of those cancer pain patients, we're trying to see them early. Is everything okay? I can hear some.
Yeah.
Okay, I'm hearing some weird sound in the background. Okay, no, that's gone now.
Okay, you're all right?
Okay, yeah, good. So but on an average, I would say 6 to 9 months.
Okay.
Would that be right, Lorinda? 6 to 9 months, roughly? Yeah.
At the moment, yes, that's the wait list.
Okay, thank you. David has another question regarding a point on your last slide video regarding CC letter to pharmaceutical services. Which letter are you referring to?
Oh, the GP letter. Yeah, so it might not apply directly to GPs. I get the point, but how would it apply to GPs? Like normally when we're writing back to the GPs, especially in the context of pain, when there is some complicated decision about pain and opioids, like in one of the cases that I discussed, where we decided to change the goals of treatment to comfort care in an elderly female who didn't want to shift from her opioids, and I thought it was reasonable that she wanted comfort care. And anything else, anything that's out of the ordinary, I sort of CC the letter to pharmaceutical services. And this is a common practice that a lot of pain specialists do. It is generally the GP letter, the letter that we're writing to GPs. So given that this talk is mostly to GPs, I guess they don't have that letter to CC, but if they're writing a correspondence to, say, for example, another GP, if they're transferring care, they can always, CC that letter to pharmaceutical services, especially if the patient is on opioids and they've got chronic pain. So it kind of covers them. What I'm doing is I'm not hiding, I'm doing this for a reason, and, lay out what their reasons are.
Thank you. All right, the questions are coming through now. All right, so this is a question. Now the SA authority has been changed and they stated you don't need to make it if the patient doesn't show signs of dependency, even if the drug will be used for more than 2 months. That's a question.
My understanding is if it's over 2 months, you would still need the authority. The only thing that I'm aware, and I could be, from what I've heard, I've actually been to a lot of conferences in the last few months, now that everything's opened up, and heard lots of people talk about this. The only major change that's coming is after 2 months, instead of actually applying for authority, they're planning to make it as an online system where you can just enter all your information online and you get an online approval instead of what you're doing now. So that's the change that's been proposed. I don't know exactly when they're going to implement it, but that's the same message that I've consistently heard in pretty much every single conference that I've been to in the last few months. But I haven't heard of this thing that it's going to completely go away. I've not heard of that. It's going to change to a much more user-friendly interface.
Okay, thank you for that. All right. Samantha is just saying, so is everyone on an opioid for more than 2 months need New South Wales authority? I think that's just a clarification.
Yes, my understanding is that they do. Yes. Unless it's a private script, they say you can get away with it, but rather you not go through that channel. What I feel is if you have a patient on opioids, yeah, put it on the paper, go through the process, have the approval, have it supported by another specialist, another GP, whoever it is that you can. And you don't have to do it as a uh, don't have to hide it. You do it and do it properly. Yes, this patient has these many problems. I can't get them off opioids, and this is what they're on. Go through proper channel.
Okay, and I guess just a little bit more clarification. This one from Catherine is saying, sorry, just to clarify, the New South Wales Health Authority form, do we only need to fill it out if the patient is on the listed medications on the web page, example, alprazolam, injected preparations, etc., or is it for all opioids, example, Norspan, endone, after 2 months?
After 2 months, it has to be all of them. Now, with the Norspan, I'm a bit surprised that the actual web page says transdermal, you don't require. But in reality, when you look at PBS or any of the other websites, you do require the authority. And all the patients that, I mean, a large number of the patients that I've seen are on Norspan, they do require the authority. So I'm not sure where the discrepancy is coming from, but you do require. And even for the patients on ORT through drug and alcohol, they need to go through the same approval process, like every time, every 6 to 12 months. Even for ORT, the drug and alcohol consultant applies for authority through New South Wales Health. And sometimes they send the patient to me to do another 12-month review for them. But yeah, even they go through the PBS authority system. There's no exemptions from there. You could get into trouble if you're just prescribing without going through the authority system.
Okay, I'm just looking, Steve has sent through something saying only need authority for named molecules. Oxycodone does not need authority after 2 months.
Oxycodone, endone.
Oxycodone.
Yeah, endone yeah, I have to look at that. Steve Kelly, is it?
Mm-hmm.
So unless endone has a special distinction or unless we would normally not leave someone on endone on a regular basis, but everything long acting after that, beyond that, requires authority. That might be a special concession for endone, but again, in normal practice, we don't leave patients on endone more than 2 months. Like I said, they get converted to SRs, and endone's only required for IR. It might be under that premise. Yeah, and most of my patients are not on endone, but yeah, everything else, all the other long actings require an authority.
Okie dokie. Maggie is saying, do you have a reference for the 2 months rule for opioid scripts? That doesn't need to be what New South Wales Health page says.
I'm not sure. What does that mean? Do you have a
Let me
reference
read it again. Do you have a reference for the 2 months rule for opioid scripts? That doesn't seem to be what New South Wales Health page says.
That's what I've used. I've worked in three different states and 5 LHDs, and pretty much across the board in every single state that I went and worked with, the 2 month rule was always there, pretty much in every state. It's across the board in Australia. It's mentioned in every conference that I've been to. There might be some minor changes from state to state, but pretty much for most of the medications, the 2 month rule exists. And you can look at, like I said, I actually don't do the prescribing, but patients do come to me for support. The GP send the patients to me for support. And the reason I brought this up is because some of the GPs said, I don't know how to prescribe. I have no idea what legislation's involved, where to look up, what authority I require. So I put it in. 2 month rule is the general magic number for pretty much all opioid authorities. There might be some exceptions here and there for endone or for some other drugs, but for pretty much most of the other long-acting opioids, benzos, you do require that. And I don't know, I've always gone by what's on that particular New South Wales Health webpage. If there is an exception for a particular drug, then fine, you go with the exception, but that's the general rule.
Mm-hmm. Okay, and Maggie has just sent through another saying she's really confused about this rule, trying to find out more information about this magic number, and she can't at present. That's what she's doing in follow-up.
You would have to look up that link for the New South Wales Health page that I've given you. And pretty much across the board, I think for all this while that I've been practicing in pain, pretty much every patient that I've seen in so many different setups has been going through the 2 month rule. So which particular medication have you not used that rule for? Like, is there any particular situation or medication that you have not prescribed it, or have not used, or have not applied the 2-month rule?
Almost all opiates is what Maggie is saying.
That is unusual. So unless you're giving them out as a private script, so not through PBS, so they don't get any PBS subsidy, you could get away with whatever you do, because it then doesn't go under the radar. You completely, then it's completely undetected. But if you've ticked PBS and they're getting PBS authority, then you need to have that other authority. That's the rule. So
Okay, and Samantha has sent through a link. It's a New South Wales Health link, pharmaceuticals, and I'll make sure that this does go out to everyone so that you can see this after this. And it says it's the pharmaceuticals doctors section 28 of the requirement. So I'm gathering that is a really helpful link in what we're discussing with today. I don't know if everyone can see that on the question, so I'll make sure that I share that with all the participants tonight. Okay. I'll take one more question because we are over time, from Emma. Emma is saying, an authority from the New South Wales Minister of Health is required to prescribe or supply drugs of addiction for non-drug dependent persons for continuous or ongoing treatment of more than 2 months for any of the following drugs.
correct.
Yeah.
That's what it is. That's exactly what's on the web page. I've just copy pasted from that web page.
Okay, and lists each of the drugs. Authority required, go to section D, drug authorization details. And she says, hi Vidya, your slide included the screenshot from New South Wales. Only the listed medications require authority according to the application form.
Yes, but most of the common medications are involved in that. Yeah. So most of the opioids or benzos are involved in that. Most of the common ones that we deal with. There might be a few forms that are not involved, but pretty much most of the reasons that I see the patients for in pain clinic, the OxyContin, the Targin, the Ficepton, most of the other formulations, they all, I mean, I don't really see patients for endone. It's an exception rather than a rule, and probably maybe they're getting away with endone on the premise that endone is not supposed to be used for chronic pain. But pretty much patients come for Panadine Forte. The GPs apply for authority for that. So I'm not sure why this confusion is arising, because most of these patients require, I mean, that's the blanket rule. Basically, I'm saying I don't do the prescribing, but the blanket rule is 2 months. And some people have gotten into trouble because, they didn't follow the process and whatnot, but that's what the rule is. You can interpret it in whichever way you want, but I'm just basically quoting what's on New South Wales Health. It's the form that you apply, you fill out and apply, and then you go for the PBS authority after that.
Okay. All right, folks, we are out of time. Steve, thank you. There is just a statement from Steve Kelly. The New South Wales webpage is the rule. It specifies only a few medications needing authority unless dependence is present. Okay, I might leave it at that.
So that might be the thing, is the patients for whom we apply for authority, maybe there is a concern of opioid dependency, and that's why. Because like I said, I don't do the actual applications, but they are on opioids, and it comes an opioid use disorder, even if it's for pain.
Awesome. All right, folks, thank you so much. Thank you, Vidya, and thank you, Lorinda, for very excellent presentations. What I might do is share these questions with you, Vidya, and then if there is any further response that we might need, we can get back to the participants who sent those questions through. So thank you very much for that. Do appreciate it. Please do complete the evaluation, folks, and don't forget that there is an echo opportunity for an interactive case discussion on this on the 30th of May. And with that, I'd say good night and thank you for joining us tonight, everybody.
Thank you.
Thank you.